Welcome to Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon in Marin, California. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Today we'll be talking about the operative treatment of an isthmic spondylolisthesis. You should have caught the prior two episodes on the imaging, the anatomy, the symptoms, the non-operative care. Today we'll be talking about the surgery for an isthmic spondylolisthesis. It happens to be one of my favorite surgeries in the spine to do because it's elegant, it uses a lot of technology, and best of all, it has probably one of the best outcomes we have in spinal surgery. I'll be posting new videos weekly, so hit the subscribe button to catch them as they come out. I just want to remind you very briefly what an isthmic spondylolisthesis is. Essentially, it's slippage of one vertebra in front of another because of a fracture or break in the back. So here's the back of the lumbar spine, and the pars is this black area here. And if the pars breaks, there's a break on that model. Over time, what can happen is that break and separation leads to one part of the spine slipping in front of another. So this is the normal lumbar spine. There's the L5 bone, S1 bone. You see the bones are nice and aligned here. The disc looks perfect. And this is a isthmic spondylolisthesis. So here's the L5 bone, and instead of the pars being continuous like it is on L4, you can see there's a break here. That's the fracture. As a result, the entire spine is slipped forward, and the back of the L5 bone is here, the back of the sacrum is there, and you can see that there's slippage of one in front of another. So again, you're looking like that. This is the CT scan. So here's a great example of where the nerves are getting compressed. So this is the side view of the back, and these are the nerves coming out. So there's the L4 nerve coming out, perfectly happy between the L4 bone and L5 bone. But there's the L5 nerve getting pinched because there's the L5 bone, there's a sacrum. As the L5 comes down there, you can see the pars, and there's this huge separation. The rest of the L5 bone is back there. So what you're seeing on this image is that black line, which is the break, is right here. And you see the fracture itself driving in to this yellow thing, which is the L5 nerve. Here's an equivalent MRI view of the degeneration in L5S1, and here's a great look at the nerve. And I'll put the nerve in yellow here. So that nerve is just getting squashed up down because that disc has no space, because the fracture is driving into the nerve, and because of up-down compression. The entire strategy of surgery is to increase the disc space to try to open up space for the nerve. In a lot of patients I see, fusion is like the F word, and nobody wants a fusion. But for an isthmic spondylolisthesis, there really is only one way to treat it. This is abundant in the literature. This has been shown in evidence-based research many, many times, and that is to fuse L5 to S1. And it makes sense, right? If there's slippage of one bone in front of another, you need to stabilize L5 and S1, glue L5 and S1 together to stop the slippage so that the nerve doesn't get compressed because of the instability. There are many, many different ways to treat an isthmic spondylolisthesis. I'm going to talk to you about how I treat 99% of the patients in my clinic who have an isthmic spondylolisthesis, and it's with what's called a minimally invasive front-back fusion. There has been a ton of evolution and a lot of different changes in technology that's enabled us to treat this problem this way. Even when I finished training 10 to 15 years ago, we were still, in order to treat this problem, opening up the entire spine with a big incision from the back, putting in screws into L5S1, formally taking all the bone spurs off the nerve to decompress the nerve, and putting in cages and screws, etc., through an open incision that big. Well, the strategy we use now for an isthmic spondylolisthesis is to try to stabilize the spine, to try to create room for the nerve, and try to lock the spine in place as minimally invasive as possible. So the first thing we need to do is address the fact that the disc is degenerative collapsed and the nerve is getting pinched up down. And the next thing we need to do is make sure that we have a good way to stick the L5 bone to the S1 bone. So one of the best ways to do that is through what's called an ALIF, or anterior lumbar interbody fusion. The second stage of the procedure is called a posterior lumbar fusion, as well as instrumentation. And the reason we have to do that is It's simply not enough to perform a fusion in the front. Because of the instability, we have to lock the bones in place. And the way you lock the bones in place is by putting screws into L5 from back to front, screws into S1 from back to front, and locking them in place with a rod. And I'm going to go over exactly what that surgery looks like. The strategy is to come from the front, take the disc out, put a metal or plastic spacer or cage in. So an incision is made, if the belly is here, an incision is made over the abdomen. Every time I tell patients I'm going to make an incision in the front of the abdomen, they totally freak out and they say, oh my God, you're going to go through my intestines, through my stomach. And what patients don't realize is that we do what's called a retroperitoneal approach. And an anterior lumbar interbody fusion is probably one of the most minimally invasive surgeries that I do. And that's because there's basically no muscle cutting at all, and the dissection is very elegant. So we don't go through the intestines or through the stomach. In fact, we go around everything. Here's a great picture of what that looks like. This is the view of the spine, and this is kind of at the foot of the bed, looking from bottom up. And so an incision is made in the skin over the abdomen here, and we go around everything and retract everything to the side to reach the disc. So in fact, we're not going through this, we're going around it, and again, it's called the retroperitoneal approach. This approach in my practice and in many practices is done with the help of a vascular surgeon or a general surgeon, because there are some blood vessels in the way that have to be negotiated. The chance of blood vessel injury is exceedingly rare, and if it happens, the vascular surgeon is there to repair the blood vessel. Once we're to the front of the spine, we completely take the disc out. And after we take the disc out, you can't leave the disc space empty. So we put a plastic cage in. This is the cage. It's a plastic cage. The plastic cage has holes in it, as you can see. And what we put in these holes is typically bone graft. Many surgeons, including myself, use something called BMP. Bone morphogenetic protein. BMP was actually on the news many years ago because there were some suspicion that BMP had a slightly increased cancer risk. At very high doses, there's some data that suggests it might. However, at the dose we use it at for spinal surgery, it really has not been shown to be carcinogenic. And BMP is one of the strongest bone growing substances we have. And I think the benefits far outweigh the risks. BMP comes in a little white sponge, and we take that white sponge and we basically stuff it into these little rings here. And once the disc is taken out, we take this cage and we introduce it into where the disc used to be. After we complete that portion of the surgery, which takes about an hour, we then flip the patient to the back, and we do that with a very sophisticated table. It's called a Jackson table, and essentially looks like a supersized waffle flipper. So we go from the patient in the supine position and then flipped 1 through 3 to the back in a totally stable, controlled manner. The reason we have to do the flip is because once we've put the cage in the front at L5-S1, we have to lock the L5 bone to the S1 bone to give stability. Because that cage in BMP takes up to 6 months to a year to grow bone. Well, we have to give biomechanical stability and rigidity to make sure that there isn't slippage or continual motion of the L5 bone on the S1 bone during that fusion process. Now, the screws that we put in the back are called pedicle screws. The pedicle screws look like this. So that's a lumbar pedicle screw. There's a side view. This screw gets inserted into the spine from back to front into the L5 bone, and then from back to front into the S1 bone. And you'll see that there's a little U-shaped part of the screw there. And that U-shaped part of the screw is so that a rod can sit inside it. I'll show you a nice model of this. This is the side view of the spine there. You can see there are screws that are driven from the back of the spine to the front. Now, you'll notice that these screws are attached by these long metal tabs. Now, there's a reason for these tabs. So I told you that we used to open up the entire spine and put in these screws. But as spine has evolved, we try to get more and more minimally invasive. Now we actually have the ability to neuro navigate screws into the spine without actually looking at and opening the spine. So how does that work? Well, we can obtain what's called an intraoperative image, meaning while you're on the table, we use a very fancy imaging modality to do almost like an intraoperative CT. Now, based on the intraoperative CT, I can then use instruments, and my screw is attached to an instrument, and the instrument is able to communicate with the computer. So I'm watching on a TV screen while I'm working on your spine so that I can drive these screws into the spine from back to front without even looking into the spine. So I'm working here, but yet my eyes are over there looking at a screen based on the intraoperative 3D imaging study. Well, what advantage does that have? First, it avoids a huge open incision because the only incision I need in order to place these screws are 2 little incisions on either side of the back. We find that patients have much less blood loss, much less pain postoperatively because we haven't completely stripped open the entire spine to do the surgery. And we use our experience, x-ray guidance, neurological monitoring despite our best efforts. If the screw is not in the right place, we'd have to come back to revise the hardware. That's a natural consequence of leaving any hardware in the spine. The entire time I've used minimally invasive neuro navigation to put screws in, I've never had to be back once to revise hardware because of the accuracy of the imaging study. I better knock on wood after that one. The way that you connect the screws again is we drop a rod there, and the reason these tabs are here is because it helps guide the rod down from the top of the body to the bottom, and then we lock these 2 in place so that immobilizes the 2 bones, and these tabs actually break off, and you can see that there's a little interface here. So we break the tabs off, so at the end, the screw looks like that. There's no tab on it. Without the tab, when we do the surgery, these tabs are sticking out of the body. If the skin surface is here, we're just looking at the tabs. Without the tabs, I wouldn't be able to work outside of the body in. The surgery in the front for a single level or 1 level surgery takes me about an hour skin to skin, and in the back with this new neuro navigation technology, it also takes me about an hour. So the surgery itself in total, from a surgical time standpoint, is about 2 hours, maybe 2.5 hours, but there is time obviously to perform the actual flip. We have to re-prep, we have to re-drape, we have to do the imaging, etc. Again, there's going to be a great video on Into the Operating Room for front back fusion from Isthmic Spondylolisthesis coming up next. From a surgical expectation standpoint, post-operatively, some patients get immediate relief of the buttock and leg pain and back pain, some don't because it can be gradual in time to see relief. Patients are typically in the hospital 1 to 2 days after surgery. I have them wear a soft lumbar corset for 6 weeks just for comfort. Most patients at the 5 to 7 day time point are walking into the office unassisted for a nurse wound check with my nurse, and most patients at 6 weeks are walking 1 to 2 miles. Full fusion is 6 months to a year, but I do start physical therapy, core strengthening, etc. at around 8 to 12 weeks, and I usually let patients back to the gym at around the 3 or 4 month time point. Again, from a surgical expectation standpoint, this is probably one of the best surgeries we do. I never like to operate on patients' low backs for back pain, and that's because usually back pain surgery doesn't work. There's one exception to the rule in all of spine surgery, and that's with an isthmic spondy. And I believe it's because there's fracture-related pain, there's disc-related pain, and it turns out if you do a fusion for an isthmic spondy, there's about a 90 to 95% chance that the majority of back pain will get better. And in terms of the buttock and leg, because, again, we've used that spacer to create room, there's about a 90 to 95% chance of the majority of the buttock and leg pain getting better. How much pain we take away depends on how badly the nerves have been damaged and what else might be causing back pain. I can usually pretty reliably take away at least half of someone's pain. From a long-term complication standpoint, obviously chance of infection, that's typically less than 1%, chance that the patient doesn't fuse together less than 1%, and chance by fusing and locking in place one of the levels, we invariably put stress above and below. So if you lock L5 to S1, you're putting stress at L4-5. there is a chance of needing surgery for that later on. That's usually 1% per year per level. So at 10 years, maybe a 10% chance of needing surgery at L4-5. From my standpoint, it's a small price to pay when patients are having 8 to 10 out of 10 back pain, buttock, and leg pain because of the instability. The biggest problem with doing the surgery minimally invasively without a formal decompression, understand what a formal decompression means is what we used to do traditionally, which is strip the entire spine open, take the entire fragment that's broken off of the nerve and physically look at the nerve to make sure the nerve is free, is that there may not be complete leg pain relief. So the strategy here is, again, to take the disc out from the front, expand that space with the spacer, and then lock in place in the back. I'll show you better on MRI. What we're trying to achieve is that by going through the front and putting a spacer in, I'm indirectly decompressing the nerve, meaning I'm creating up-down space, but I'm not physically looking at the nerve. I'm relying on the fact that that spacer is going to give enough height when I put that spacer in, that height is going to create room for that nerve, and that nerve is going to be comfortable. Again, I'm not formally decompressing the nerve. When you do a front-back minimally invasive surgery, you're totally relying on indirect decompression. That means a small percentage of the time. In the literature, it's about 5% of the time at a year's time. If a patient's still having buttock and leg pain and there's still persistent compression or the indirect decompression wasn't enough, we'd have to come back, make a formal open incision, take the pressure, and take the fracture fragment off the nerve. In the last 10 years, I've had to do that one time. So most patients, if you get a good reduction, if you get good amount of space, actually do quite well with this and do not need a formal decompression. There's some debate in the literature on this, but I think most spine surgeons are moving towards minimally invasive anterior posterior fusion for an isthmic spondylolisthesis for indirect decompression. This is a good image of what happens with the indirect decompression of surgery. So this is the patient's x-ray showing the degeneration at L5-S1. There's the L5 bone, there's the S1 bone. Here's the L4 bone. Disc at L4-5 looks great. There's the nerve for L4-5, looks great. Very different than here. So this is the L5 nerve, and again, that is a nerve that's coming out here, and it's getting squashed because the disc is collapsed because there's a fracture here and the fracture is hitting that. So there's the fracture right there, that defect, and that nerve's getting squashed. This is one of my patients who I did a front back minimally invasive fusion in. So this is the cage that goes in the front. That's the anterior lumbar inner body fusion portion. And there are markers in the cage. Right now it shows up as just gray space, and you can even see a little bit of bone already starting to grow. But here's a marker, there's a dot, kind of hard to see. There's the line, which is the back of the marker. But what I want you to appreciate is the difference in disc height between here and here. So you can see that that flat ribbon of a disc was taken out, and we slowly jacked the space open between L5-S1 using that cage to create space. And the space that we've created is now allowing the nerve to expand. And in the back, what we've done is we put screws in minimally invasively, and we put a rod in there. You'll notice that there's a little screw and washer here. The reason we have that in is it's called a butcher screw and washer. So after we put this cage in, I want to make sure the cage doesn't float around during the flip. So to prevent that, we put a little screw and washer there just to hold it in place as a retention when we flip. And so what's happened is you can see the L5 screw, the S1 screw, and there's a rod. That's the washer and screw, which is that guy. And L5 screw, S1 screw, and a rod. So this patient actually had a great outcome, had almost complete relief of his back pain, buttock, and leg pain. And I have one final model to show, which is what it looks like from top down. So this is a great acrylic model that shows the screws that have come in from back to front. So these are the screws that I showed you earlier. They come from back to front, and you can see that there's a cage right here that was placed. This model happens to have screws in L4, L5, and S1, and only a cage at L4-5, but you'll see the idea of the cage here, and then you can see the rods that are kind of locked in. So for an L5-S1, all you would see is this segment here. I recently saw one of my patients back who was a year out from having the surgery, and I took the opportunity to film him in the clinic. so he could talk about his experience of what his symptoms were, what kind of relief he got at the 1 year time point. So Sal's today 1 year after a front back fusion for a fracture at L5, a slippage at L5S1, back pain, leg pain. So tell me about the symptoms you were having before surgery, and tell me how you're feeling today when you're out.
Well, surgery was about a year ago, you said. For at least a few years before the surgery, my symptoms were my right leg would pretty much go numb if I walked more than 100 yards. I had pain in my right buttocks, a little bit of pain in the back, but it was mostly my right buttocks and then all the way down my right leg, and the numbness, and to the point where I'd have to sit down, and that would relieve the pain. I'd have to sit every 100 yards or so if I was going for a walk.
And what activities could you not do that you wanted to do? How was it limiting your quality of life?
I've always been pretty active. I'm an avid golfer, and I hadn't played golf in probably 3 years because of that. Played a little bit of tennis, nothing to write home about, but couldn't do that either.
Okay.
So other than going to the gym and not being on my feet very long, that was the extent of the exercise I could do, and it was really bothering me because I'm very active. So it pretty much shut me down for about 2 years or so.
Okay, and now we can look at the camera, and I want Sal to tell Spine Guy viewers, I want Sal to tell the Spine Guy viewers what he's doing now, how he's feeling now a year after surgery.
If you had said to me a year ago I was going to feel like this, I wouldn't have believed you. I feel terrific. I mean, I shouldn't say this because maybe I shouldn't be doing this, but I actually played 2 rounds of golf last weekend. I'm back on the golf course. I'm exercising. I'm riding my bike. Absolutely no pain, no numbness at all. I could not feel any better than I feel right now.
Perfect. So Sal, we see you hopefully never again.
I was just going to say that.
Totally
on the
fused,
street, right?
And you keep on golfing, okay?
Thank you. Appreciate
All right, buddy. So there you have it, another successful front back surgery from Isthmic Spondylolisthesis. Again, probably one of my favorite operations to do just because of the great surgical outcomes. I look forward to showing you into the operating room so you can look at all the technology we use to introduce these screws and just how spine surgery has advanced even in the last 5 to 10 years. Thanks for watching. Don't forget to click the like button and leave questions or feedback in the comment box below. Feel free to let me know what videos you would like to see in the future.